for a very long time, we've not been able to put this meeting like this together, where we invite the partners, where we invite colleagues from the health sector, from the HIV/AIDS, to have a conversation on what needs to be done to improve on our work, to strengthen our partnership. So this morning we are really excited that you've been able to come, so you're welcome. Let me now take this opportunity to invite the acting chair of the Inter-Religious Council of Uganda.
As you may be aware, faith-based organizations are not just recipients of aid. We are active and powerful partners in development, holding significant assets and influence. For decades, our institutions have served as cornerstones of care, providing healing and hope in the most underserved areas. We have not only treated bodies, we have nurtured souls, offering hope and compassion in the face of adversity. Our networks, which include hospitals, clinics, and community outreaches, are closest to the people. We are often the last line of defense against disease and the first point of care. As the burden of care increases, our traditional funding models are being tested. Therefore, today, we are here to speak about the future, not only of our health facilities, but of our mission of delivering a divinely peaceful, united, and prosperous Uganda, where all people enjoy full health and freedom for the common good. As religious leaders, our scriptures command us to take care for the sick, support the vulnerable, and protect the sanctity of life as a scared duty. However, while we remain committed to this ministry of nature, treatment, and healing, we recognize that our efforts are part of a broader ecosystem that requires sustainability. Guest of honor, we recognize the remarkable progress made in improving health service delivery and HIV prevention in Uganda. We have witnessed increased government investment toward strengthening our health system, backed by strong external support. However, this model is now under strain, even as our expectations continue to rise. Citizens desire better quality services, closer to where they live, and without the financial shock that so often accompanies illness. The scientific advances we see today have offered the country a real opportunity to improve well-being and end the AIDS pandemic as a public health threat. However, as funding shifts and donor reliance becomes unsustainable, we risk losing the gains we have worked so hard to achieve. We are also witnessing a country still faced with complex, intersecting challenges that threaten efforts to deliver equitable health services and end AIDS as a public health threat. For many Ugandans, immediate survival continues to outweigh long-term risks. Daily struggles of poverty, food security, and employment often take precedence over long-term health concerns, which may appear distant in comparison. Similarly, the constant presence of endemic diseases such as malaria, HIV, and TB have led to the normalization of illness, where these conditions are perceived as manageable rather than urgent. We have also witnessed a gradual decline in the intensity and the coverage of behavior change campaign messaging since the advent of RT and other HIV prevention technologies. Yet, it was these campaigns that motivated behavior change, particularly amongst those who witnessed the suffering caused by AIDS. We are now concerned that younger generations who did not witness this period may lack the same urgency and awareness. Therefore, while investments in science are commendable in reducing AIDS-related deaths, the success of RT in Uganda has also contributed to increased complacency in the fight against HIV, creating a prevention paradox. Uganda imports over 90% of its medicines, exposing the country to external shocks, supply disruptions, and high costs. The country is estimated to lose approximately 10 trillion Uganda shillings annually to corruption, representing about 44% of government revenue, significantly impacting public service delivery. At the same time, non-communicable diseases such as diabetes and cancer account for 35% of deaths in Uganda, yet remain among the least funded health priorities. In this new reality, health is no longer only a social priority, but also a financing challenge and a test of our economic strategy. While government is investing in health, the question remains whether this investment is sustainable and delivering value. External partners still finance the largest share of the health and HIV budget, which government contributing about 22%, households contributing 31%, and private insurance contributing 5%. Consequently, over 206,000 households, nearly 1 million people, are pushed into poverty annually due to out-of-pocket health expenditures. Guest of honor, we are further troubled by the inefficiencies in the use of limited resources. While the cheapest disease to treat is one we prevent, Uganda continues to spend more on treatment than on prevention. This imbalance generates recurring costs, crowds out other investments, and reinforces systematic inefficiencies. We are also concerned about the effectiveness of health and HIV risk communication, which has not sufficiently adapted to local contexts and has often failed to engage community leaders, creating a disconnect between public health messaging and local realities. These realities demonstrate that our health care system is still in transition, expanding, yet not performing optimally. This raises important questions. One, should the country prioritize health insurance or direct service provision? Two, prevention specialized care. Three, infrastructure or functionality. For us, the answer may not lie solely in the choices we make, but in how we sequence them, a challenge our country has historically struggled to address. As a faith community, we believe that our country is not entirely short of ideas or resources, but rather challenged in execution. In response, The Inter-Religious Council of Uganda calls upon the government and partners to support the proposed root cause and trusted messenger strategy. This approach shifts focus from science alone to leadership that addresses societal drivers of HIV and other behavior-related illnesses, repositioning religious institutions as centers of spiritual and social transformation. Let us be a space for open and constructive engagement on how we can better align our efforts towards achieving universal health coverage. Let us use this opportunity to rethink, rebuild, and strengthen our health system.